This is a model of doing therapy called ISTDP. I'm passionate about it. I like it a lot. It's flexible. You can adapt it to what you're already doing, CBT or something else. You can adapt it to working with kids. So keep that in mind. It's not like you have to wholesale buy the whole thing. But this is something that I am passionate about. So here we go. ISTDP. So there's a lot of material that I'm trying to get through. I've already tried to pare it down, but it's still quite a bit of material. So I was thinking if you have comments or questions, scribble it down or file it somewhere where you can remember it at the end. Hopefully we'll have some time for Q&A. Also, I am getting to an application section towards the end, which is, I think, the fun part. You're actually going to see how the model looks when you apply it. But in order to protect confidentiality, I've actually added some fictitious material, and the vignettes are inspired by real clients, but I wanted to protect their confidentiality. Okay? So what does that string of letters stand for? Intensive, short-term, dynamic psychotherapy. Intensive because we aim to help the client experience their feelings as fully as possible. Short-term because we try to do it as quickly as possible. And dynamic because we work with unconscious or implicit processes of the mind. Short-term is somewhat of a misnomer. It's short-term compared to analysis proper, which is 5 years on the couch kind of thing. So compared to that, it is short-term, 40 sessions or less on a case-by-case basis. And it was founded by Dr. Habib Davanloo, a psychiatrist from Iran. There are fundamental differences between the psychodynamic approach and some of these other models. And I know that depending on where you went to school, the word psychodynamic might be like swearing in church. So I'm going to begin by trying to bridge some of the gap. And then I'm briefly going to look at the evidence base. We're going to look at a nutshell version of really what it is and why emotions is such a central focus in this model, historical context, some of the theory, and then what I think will be the fun part, which is the application. We'll look at 3 different vignettes. One of the vignettes is going to be about cancellations and no-shows. I'm sure no one in this room can relate to those. And then some cultural considerations, and then we'll wrap up. All right. So if you look at behavioral therapy, exposure, right, desensitizations are key components. And it's the same in ISTDP. It's actually essentially an exposure model, except exposure to intrapsychic phenomena. And so exposure and desensitization are huge parts of ISTDP. The schema, core beliefs of CBT, very akin to maladaptive defenses. We call it that in ISTDP. Response prevention and CBT, very much like ISTDP's defense interruption. CBT's challenge of maladaptive beliefs, much like ISTDP's use of pressure and challenge to give up maladaptive defenses. All right, EMDR, right, clearing channels, that's very, very similar to unlockings in ISTDP. There's the concept of irreverence and DBT. That's similar to what we call head-on collisions in ISTDP. If we look at motivational interviewing, we have rolling with resistance and then in ISTDP we call that mirroring resistance. We do that when the resistance is ego-syntonic. And then also obviously getting permission is really big in MI. That's really big in ISTDP. You really want to make sure that the client really wants to do the work, that you have their permission to do the work. Okay, evidence base. So there are actually over 50 research studies that look at the outcome data showing efficacy for this model. Don't have time to go into all 50 of them. I thought we'd look at 1.5. Most of them are randomized controlled trial studies, which I'm sure most of you know is really the gold standard when it comes to research. All right, so in a nutshell, this model of doing therapy aims at helping patients take charge of their lives and to feel autonomous as opposed to blindly reactive, while at the same time removing obstacles for healthy attachment and enjoying bonding. So from the view of ISTDP, personal autonomy and healthy attachment and bonding are seen as both equally important and complementary drives. So at heart, this is a model that tries to help the patient connect with self and others through befriending previously disavowed parts of the self. And it tries to do so by overcoming resistances to experiencing these parts that have been either too painful or scary to face. And the way to do that is to utilize what's called central dynamic sequence. This is like a one-on-one presentation. I don't have time to go into the details of it, but maybe in a 300-level presentation, we can do that. So the understanding of ISTDP is that insight alone is not enough. Experiencing feelings alone is not enough. It's really the integration of cognitive insight and affective experience that seems to cement therapeutic change. So it's all about integration. So this is a highly experiential model. There's a strong focus on the here and now, real-time experience. ISTDP geeks, we call it working in the T, working in the transference. And it was good old Frida from Reichmann who said that the patient is in need of an experience, not an explanation. And that is very much the spirit of ISTDP. Explanations are very important in terms of helping the patient make sense of their new experiences, put them into perspective, very important. But just explanations alone, without new experiences, tend to do very little to affect lasting change. Okay. So this model, right, the aim, it goes beyond symptom relief. It really aims to affect character change. It seeks to find the collaborator or the co-pilot, if you will, in the patient and really try to get at the very engine of symptom formation. The therapist is very direct about real-time observations about how the patient relates to the therapist, to herself, and the therapist tends to be quite active in identifying, both verbal and nonverbal behaviors, and connects these to the patient's chief complaints and their goals. So, and the therapeutic task of this model, sort of the quick and dirty version, is to let go of maladaptive defenses and avoidance behaviors at a pace that's tolerable, of course. To face what makes you anxious rather than avoid it. Face and experience previously warded off feelings, and learn how to channel those feelings into adaptive actions rather than avoid them and cover them up. So part of this model is that it's an intervention response model. It means that it's an interactive diagnostic procedure. And an analogy before I get to the analogy, pressure is actually a key intervention in the model. Pressure can often come in the form of pressure towards exposure, right? Remember, it's an exposure model to previously avoided psychic material. An example of pressure would be, I noticed that you look away a lot and that you frequently change the topic. Would you be willing to stay focused and present here with me so that we can better help you with the problems that you came here for help with? That would be one example of using pressure in this model. Okay? And so the diagnostic picture, it forms through pressure. And again, the pressure can take many forms. Pressure to be engaged, present, pressure to notice and self-reflect, pressure to stay on track, pressure to experience feelings. And so the analogy that I like to use, it's like air that's pumped into a bike tire. ISTDP applies pressure into the patient's system in order to properly psychodiagnose. So with the bike tire, where the air seeps out, you see where the problem is. And the patient's response to pressure really gives the diagnostic picture. Okay? And so what does that mean, diagnostic picture? It's not in a DSM sense, but what we're looking at is essentially the patient's ego-adaptive capacity. In other words, their self-functions, their ability to identify and express feelings, ability to self-reflect, to do their half of the interaction, the dialogue. We look at how egosyntonic versus egodystonic their defenses are. One very important index that we look at has to do with ego fragility versus ego strength. The importance of paying very close attention to that dimension is it lets us know when to use more challenging interventions and when we need to back off and help the patient regulate their anxiety. And the three ways that we determine someone's ego strength or fragility is we look at their channels of anxiety discharge, we look at types of defenses used, and whether or not their reality testing is intact. So there are some contraindications. Psychotic conditions such as schizophrenia, active substance abuse, serious adult antisocial behaviors, certain life-threatening psychosomatic conditions such as ulcerative colitis, those unable to function without constant support, as well as patients whose cultural preferences include wanting to forego their individuality for the sake of the group, developmental disabilities, people not voluntarily in treatment, and individuals that are simply not motivated or interested in doing in-depth uncovering type work. All right.
Are we doing questions?
Well, if I don't like the question, I'll shoot you down. But go ahead.
So who does that leave, though? You had a whole list of things, but who does that leave? Are you going to talk about that?
Well,
who is it?
Everyone who doesn't fit those categories. So general mental health, anxiety, depression, people with trauma, but they're not actively using substances.
Okay.
So,
got it.
So if you don't have a psychotic process going, you're not actively using substances, and you're really motivated to resolve your symptoms, you're probably going to be a good fit.
Okay.
All right. So the model is really an emotion-focused model. So, and why is that? So from the model's point of view, one reason that many forms of therapy fall short is that they're attempting to alter the emotional brain, which is often automatic and irrational and not fully conscious, with the rational reasoning brain, which according to neuroscience is by nature always a step behind. So let's have some fun with neuroscience for a minute. From this point of view, the emotional brain rules. There was a study that looked at the speed at which certain stimuli register in a given area of the brain. And so if you look at the brainstem, we had stimuli registering at approximately 50 milliseconds. Okay, then we have the limbic and amygdala part of the brain, like instincts, emotions, at 150 milliseconds. And then we have the straggler, the neocortex, down here at approximately 450 milliseconds. So it is far behind. And what does that mean? What's the so what of that? Well, it means that we chase our feelings, that rational thought is always playing catch up with the emotional and often irrational and not fully conscious processes of the mind. Advertising companies know this very, very well. They know that, which is why ads that play to our emotions and to our appetites are generally much more powerful than ads that merely play to our rational minds. And also common experience. We know that at a lower level emotional upset, we might be able to reason ourselves out of it and talk ourselves out of it. But if we're really upset, that's usually it's not going to work. So the implication is that lasting therapeutic change needs to address the emotional dimension of the patient, and we can't just reason ourselves out of our problems. Go ahead.
This might be too difficult, but that first one, on the surface, it seems to be an exact opposition of what I believe, is that the thought creates the feeling.
Totally.
So
Totally. No, this is a fundamental difference between ISTDP and CBT. So what you like, take it. What you don't like, just reject it.
Okay, so that is clear what it's saying. First you have a feeling,
Right.
and then you have a thought about why am I feeling that?
It's totally opposite from CBT. So just take what you like and disregard what you don't.
Well, this is rational thought, so I'm wondering if maybe the feelings tend more to drive the irrational thoughts rather than...
And that's what I was wondering, if there was more to it than that. Is that, in my model, which is not this,
Right.
right? If something happens, we have an event, then we form, what just happened? That thought, it's that thought that leads to the feeling.
Right.
Does that fit at all? And then the rational thought comes after to go, why am I feeling this? And was that thought reasonable?
Yeah, I'll show you how this model looks at that whole thing. It's different. It's different. You're totally right that it is different. Hang tight. So in order to drive the point home, and this actually speaks to what you're getting at, I wanted to look at an example. And so I'm using the example of the belief that I am bad, okay? And let's say the belief is sourced to father's abuse, okay? So let's look at it. Father abuses child. The child is dependent on the father for survival, okay? It's too scary for the child to acknowledge the reality of the father's abusive behaviors, as well as angry feelings towards the father. So the child has little choice but to turn that negativity back on the self in the form of the thought that I'm bad. So this takes us to an important concept in this model called the triangle of conflict. There it is, I've drawn it there, but it essentially says that stimuli in the environment triggers feelings and impulses, which mobilizes anxiety, which triggers defenses used to manage the anxiety. Okay? Keep that in mind, it'll keep popping up. So if we go back to the example, so the belief I am bad here has a defensive function. It wards off seeing the reality of the father's badness and abuse and anger towards him for it. So therefore, helping the patient face the anger and other complex feelings towards the father, and perhaps other genetic figures, resolves the belief I'm bad, since the belief serves the function of avoiding those emotions. So, again, the triangle of conflict, the feeling, anger at the father for being abusive, anxiety up here, this corner, if father sees my anger, he'll punish me. So then defensive self-attack, I am bad, which temporarily lowers the anxiety and preserves the bond with the father. So this triangle of conflict is really the ISTDP's understanding of interpsychic causality, which is different than CBT.
It's interesting because wouldn't having the defensive belief of I am bad raise the anxiety in itself? So maybe it resolves the family dynamic anxiety, but then doesn't it just in turn raise
long term for sure. In the moment, it'll lower the anxiety because, okay, father's not going to see it and so on. But long term, yeah. I agree, that's a really good point.
That will also create cognitive dissonance.
Yeah.
If there's ever a moment when I don't think I'm bad, it's going to conflict with the belief.
There you
I
go.
want.
There you go. Yeah, this model is flexible. You can adapt it and assimilate it into whatever existing frameworks you use.
I like that.
So,
Yeah.
so again, it's really the integration of cognition and affect. So cognitive insight here is I'm not bad. The thought that I was bad was hiding that I'm mad or sad, right? The emotional experience. And so it's the acknowledging the feeling coupled with the cognitive understanding that the belief I'm bad once served a necessary defensive function. And that's really what cements the therapeutic change. It's the integration of reason and emotion. So you might ask yourself, why would I want to feel these feelings? Maybe they're terrible or it feels terrible. And so for many, right, feelings are associated with very high levels of anxiety or painful ways of managing that anxiety. And so what ISTDP does, it engages the patient in the process that begins to decouple affect from anxiety and defense. And this process of differentiating feelings from anxiety and defense is called restructuring. It involves desensitization work and substituting regressive defenses for higher order defenses in order to build affect tolerance capacities in the patient. So, therefore, when feelings are experienced without anxiety and defense, they're differentiated from the patient's previous negative associations to these feelings. It tends to lead to a pretty empowering experience for the patient. They tend to feel more uplifted, more assertive, their mood tends to improve, no longer drained by draining mechanisms, strategies for managing anxiety. Okay, so that would be the reason. Let's see, how am I doing with time? I'm going to go ahead and skip historical context. Remember, I'm going to email you these slides. So I really want to get to the application section, that's why.
So do
Yeah.
sounds like fun.
Same with theoretical underpinnings, but I can just summarize the theory in some. Essentially, it derives from the attachment model, attachment theory. So here, relational traumas arouse complex feelings towards caretakers. Okay, relational traumas mean anything from abuse, neglect, to just misattunement. And children hide those feelings through habitual defenses to maintain their attachments. And this helps them get through childhood, but again, as you pointed out, Laura, it tends to be what brings them to therapy and creates the symptoms. All right? So, yay, the fun part. So remember that the ISTDP therapist is very direct about real-time observations of the patient, what she's saying, what she's not saying, body language, and so on, and then connects these real-time behaviors to the patient's problems, their goals, and their difficulties. All right? A lot of times the patient has a reaction to these observations because they are so direct and they're so personal, but in ISTDP, that's grist for the mill. Then you just examine those reactions. Okay? All right, so basically the therapist tries to get an understanding of what's happening and get a consensus with the patient on what's happening. Is what's happening connected to their goals and their problems? How pervasive is the problematic pattern? And is the pattern problematic enough that the patient has the motivation to actually try to let go of the avoidance strategies and face the underlying feelings that these symptoms and defenses have warded off? Okay, so let's get on with the show here. No-shows, cancellations. So here we have a patient. I'm going to do this in transcript format. So the patient's chief complaints, difficulties in relationships, problems keeping jobs. The patient has a pattern of both no-showing, canceling, and not engaging in regular and consistent treatment. So that's the situation. So, therapist. Can we look at what's going on that you haven't come here regularly? It may have some implications for our work, and it may not. But so I'm not flying blind as to what's going on. You just explain to me what's going on, that you're not consistently coming to our agreed upon therapy appointments. So what am I doing? I'm just pointing out the reality of the situation. Here's what's happening. Right? Patient says, I've had a lot going on, that's all. Well, like what? I'm just trying to understand what's happening. Patient, lots of stress about work and my boyfriend. It's a bit chaotic right now. See, this is a pattern though. Over the course of a few months, you canceled 3 times, no-show twice, and withdrawn from therapy for 3 weeks last month. As your therapist, my interest is in understanding the meaning of this pattern. You withdraw from things that you enjoy. So what am I doing? I'm pointing out the reality of the pattern, and I'm signaling to the patient that this might have something to do with how they feel about treatment. Well, I have so many appointments that I have to go to. Sometimes it's a bit much. Well, I appreciate you sharing that with me. It sounds like this is another appointment that you feel obligated to go to. And so maybe we can take a look at how you feel about coming here, as well as review what your goals were when you first came, since it sounds like we've lost our focus and maybe these sessions aren't as productive as you would like. Okay? Patient says, well, you actually keep things pretty focused when we meet, so it's not that it's not productive. It's more that it's overwhelming to really work on my issues. Therapist, well, I appreciate you being so clear with me. So you're saying that you have a reaction to the way I try to keep us focused and on track, and it looks like you deal with that reaction by becoming overwhelmed, and then withdrawing through canceling and sometimes no-showing. Did I get that right? So here I'm putting the patient on the triangle of conflict.
Is this pressure?
Mild pressure. So, right, it's first thing. So they're having a reaction to something about the work. Feeling, they have feelings. That leads to anxiety, up here, anxiety, and then defense, withdrawing. Okay? So this is the triangle of conflict that I put them on. It keeps popping up. All right. Patient, yes, that's fair to say. Therapist, okay. And is that just in here with me? that when something happens that's frustrating to you, that you sometimes deal with that by withdrawing. So what am I doing? I'm establishing that this might be a pattern. Okay? Patient, right.
Yeah.
Yes, quite a bit actually. My boyfriend hates it when I pull back. Well, I'm not your boyfriend's therapist. He'll have to find his own therapist. I'm wondering what it's like for you to deal with frustration in this way. Maybe you're okay with it. So what am I doing? I'm blocking the projection onto the boyfriend, and I'm returning to the patient's own motivation. Patient, no, this is why I can't hold a job, and it's really been a problem for me in relationships too. Oh, I see. Well, it's clear that it interferes with your progress here with me, but are you saying that even outside of here, it's problematic for me? So what am I doing? I'm just making sure the patient is really motivated to change this.
Are you doing this over the phone?
No, this is in a session.
Okay.
Yeah.
But could you, like, if you were calling them? Because that's what the assumption, I assumed you were on the phone with this person.
Well, on the phone, I would say, why don't you come in so we can talk about this?
Okay. Okay.
Yeah, I would rather do it in person.
Right.
So the patient says, definitely, it is a problem for the patient outside of therapy. Okay? So then the therapist says, so could we take a few minutes and take a closer look at this pattern so that maybe we can find an alternative way for you when it comes to dealing with your frustration? So I'm outlining the therapeutic task. Patient says yes. Okay, so if you look at your last no-show, you had two options. You could have called and canceled or just not show. And you chose the latter. You just didn't show. So what do you think that was about? What were you trying to communicate by not calling to cancel? I'm just trying to understand this, since you're saying this is a problem for you in your life, and the pattern is being replicated here with me in our work together. So what am I doing? I'm highlighting the reality of the situation, and I'm inquiring into the meaning of this pattern. What does it mean? Okay? Patient, well, I'm embarrassed now. It's hard to explain. Well, my interest is really just to understand you. Perhaps this is not the focus you're wanting for today's session. Is there something else that seems more important to you for us to focus on today? So what am I doing? I'm making sure that the patient is really motivated to address it. I'm actually offering an out. If they take it, they take it. If they don't, they don't. This patient did. No, I'm glad you're bringing it up. It's definitely my pattern. Okay, then can we work together to put this reaction of yours into words? And then if you decide to not cancel again, at least we'll both know what it means. So what went through your mind when you decided not to call and cancel? Outlining the therapeutic task. Patient, that I don't need the help. I can do this on my own. So then I say, got it. And you said that you sometimes isolate from your boyfriend and tell yourself that you don't need him as well. So then why did you come back to see me? So then what am I doing? I'm demonstrating that I'm taking the patient's communication seriously. This is what they said, and so I'm just not wondering why they're back. Patient, I think I do need help actually. I've been fired so many times for going off work too. Oh, I see. Okay, so we have established that this is a tendency that you have to wall off and be alone with your problems. And not just with me, it's with your boyfriend as well. And you also withdraw from work with the consequence of losing jobs. And on the surface, you might say, gosh, this is problematic, but are you sure it is? I mean, you've been doing this for a long time, right? So what am I doing? I'm formulating the problem, and I'm making extra sure that the patient is really motivated to address it. Patient, I think I just tell myself I don't need anyone to push people away, but I don't really want to be alone, and I need to make money, so this isn't working anymore. Oh, I see. So this is really a destructive pattern in your life. It really is. Okay. So this had to come from the patient. It would not have worked with me as the therapist would have just said, this is really destructive. It really has to come from the patient. Okay. So the therapist then why don't we examine this a bit closer? Was there something in particular that triggered you withdrawing this time, a few weeks ago? So I'm just proceeding with inquiry and understand what triggered it, right? So we have consensus on the pattern being problematic, that's been achieved, and then proceed with an examination of what precipitated the pattern this time, okay? So that's one example of how an ISTDP therapist might deal with no-shows and cancellations. So key points, right? A therapist highlights the reality of the situation. Therapist helps the patient see that in this case, it might be in other cases, but in this case, it was not just about being busy or having too much going on, but instead the pattern is related to resistance in regards to treatment. And the therapist makes sure again and again that the patient finds the pattern problematic and is motivated to change it. So then there was consensus on what was going on, that it's a problem and so on. So then I had a therapeutic alliance, right? All right. So here we have a patient who presents with chief complaints of entering abusive relationships, depression, anxiety. In session, the patient has a tendency to take a passive position, to dutifully answer the therapist's questions, but without a sense that the patient is actually really emotionally engaged in the process. So the intervention goes like this. Do you notice how passive you are here with me? It's like you invite me to drive the session and you take a backseat stance. Are you ever like this outside of here? So I'm identifying what's happening and I'm establishing whether or not it's a pattern. Patient, yeah, I tend to be passive. Okay, because this passivity creates a vacuum in the relationship, and then your life is loaded with people willing to fill that vacuum. And I'm wondering if that's not your string of abusive boyfriends. So in here, when you invite me to take charge of the session and fill the vacuum that your passivity creates, and that's understandable that you do that, by the way, because why would I be an exception? This is what you do outside of here. But however, if I do fill the vacuum that your passivity creates, do you see how we would be repeating your old patterns when you allow others to take charge of your life? Does that make sense? So I'm highlighting the cost to the patient of maintaining this passive stance. The patient responds, yeah, that actually makes a lot of sense. I don't feel in charge of my own life. Well, I can't imagine that that's very satisfying. Do you think that this tendency you have to take a backseat stance in relationships could be connected to your anxiety and depression that you also wanted my help with? So I'm connecting real-time defensive behavior to the rest of the symptom picture. Patient, yes, and she takes a sigh. The sigh indicates that there's striatus signaling, suggesting that feelings are coming to the surface and it's time to begin to look at them. So then I say, okay, so can we take a look at what feelings are coming up in here with me as we together begin to examine this passivity, this way that you have of being emotionally disengaged and not in charge of your life. All right, so then that takes us down the path of examining feelings. Okay? All right, last vignette. Here we have a situation where there's not an introspective focus. So the idea here is that if the patient remains focused on externals, sessions often amount to venting sessions, and typically not much will change, just through venting. So, let's see. Patient. My wife wanted me to come. She thinks I have depression. Therapist. Since I can't help your wife with her problems, is there anything you want me to help with? What am I doing? I'm blocking the projection onto the wife. I'm highlighting the reality of the limits of my influence. I can't do anything about your wife. And I'm inviting the patient to declare a problem that he actually wants to work on. Okay? Patient, I'm tired of my wife nagging me. Well, since I don't have any influence over your wife, how were you hoping that I could help you? Again, I'm highlighting the reality of the limits of what I can do. Patient, I just wish my wife would stop nagging me. Of course, I get that. Now, but do you think that you're handling the situation with your wife as well as can be expected? Or is there anything about how you process or respond to your wife's nagging that you also find problematic? So here I'm just directly asking whether or not the patient thinks that he has a problem other than his wife's nagging. Patient, it's mostly her that's the problem. I see. You say mostly. Does that mean that you have a small role in your difficulties as well? Well, maybe 5% is me. I do sulk and withdraw sometimes. 95% is her though. Okay, well what that means is that I can only help you with 5% of your difficulties. Will that still be worth it to you? I'm clarifying the area that can be addressed through therapy, and I'm checking out whether or not that's even worth it to the patient. Just 5%? Well, sulking and withdrawing is no fun. If you can help with that part, I'd like to get out of business. So the key points here were that there was no introspective focus, right? We were externally focused. it's first the wife who has a problem, then it's the wife's nagging. I clarified the limits of my influence and then basically directly asked if he thought he had any role in it whatsoever, and if so, even if it's tiny, 5%, would it be worth it to him to work on that? So, this is considered an advanced model. It's supposed to be short-term, but it takes a long, long time to learn how to do it well. There are different schools of the model that espouse different methods, but at heart it's really a model that tries to help the client face what's previously been too frightening or painful to face, so that they can really move on with their lives and be free.